Good morning, everyone. Welcome to our third and last day of the fifth Family Medicine Conference. We'll be starting with session 6, titled Navigating Adolescent Health, Abuse, Disorders, and Well-Being. And we'd like to welcome our moderators, Dr. Nada Al-Amiri, Dr. Mahdi Al-Hashimi, and Dr. Tayba Al-Hassan.
Thank you. Good morning, everyone. Today, we are incredibly fortunate to have with us a luminary whose contributions have reached in primary health care. Our distinguished speaker, Dr. Jay Verma, is the epitome of excellence and innovation in the medical field. Since 2014, under Dr. Verma's astute leadership, the Shakespeare Health Centre in London has not only thrived, but also transformed into a beacon of visionary patient care. This remarkable facility, which is nestled in the heart of one of the world's most vibrant cities, stands as a testament to this medical prowess and forward-thinking approach. Among the numerous accolades received under Dr. Verma's stewardship, a standout is the UK National Award in 2017, which celebrated the center's pioneering strides in diabetes care. His ingenuity further manifests in his collaborations with hospitals to seamlessly integrate community services into primary care, notably reducing pediatric specialist consultation waiting times from 18 weeks to just 1 week, a groundbreaking initiative that was recognized with another prestigious national award. Dr. Verma's contributions to medical literature are both rich and extensive. He is an active collaborator with esteemed medical journals, contributing as a peer reviewer and author. As the lead of the General Practice Division at the Royal Society of Medicine, Dr. Verma espouses and propels innovative medical practices, fostering an environment ripe with innovation and growth in healthcare. Dr. Verma will be presenting 2 lectures. The first one is the impact of obesity on adolescent health. The second will be the unique challenges and opportunities of adolescents in primary healthcare. Just before we welcome Dr. Verma to the stage, I would like to kindly remind everyone to hold all questions until the end of the talk. This will ensure a seamless and engaging presentation, followed by a comprehensive question and answer session where Dr. Verma will address your queries. Please use the QR code visible on the screen to post your questions. So without further ado, Dr. Verma, you are most welcome, and the floor is yours.
Shukran.
Thank you.
Wa alaikum assalam. So, thank you very much for the hospitality you've shown for the last 3 days, and well done to you for surviving until today as well. Part of what we wanted to talk about was form the structure of the talk today. So, talking about the impact of obesity on adolescent health. So what do we want to achieve out of this? Well, we want to have a better understanding of obesity in adolescents and discuss ways in which to reduce the incidence of obesity. Primary care is preventive care, primarily. And of course, we do have treatment options, but should be reserved for last if we can. So some of the objectives I would love to share with you is trying to use data to drive change behavior among clinicians, and I should actually add, and patients too. Think about the proactive steps to influence change of behavior and deploy lifestyle medicine to improve patient well-being, and I'll explain the benefits of this in a moment. So, for this talk, data. I must admit, while researching for this presentation, I had no idea that Kuwait was ranked number 9 in the world with 25.35% of children that are obese. And furthermore, I didn't realize that it was ranked number 15 in the world with 34.28% of adults that are obese. And of course, what we do know is, of course, mortality and morbidity rates are very much more linked to the manifestations of obesity. And we can see from this graph that the predicted incidence of diabetes is likely to just rise year on year. We also know from the Sustainable Development Goals indicators, which has been published by the Kuwaiti government, is also showing that the mortality rate from diabetes is increasing. And as you can see from the graph, the bar chart, where the cancer remains very much more steady in these years, you can see the shot up in the gray color of diabetes rising. And so that's reflecting the mortality from diabetes. So if you think about this, the way we're structuring this talk is you already know the problem. And I think it's just forming data around that problem to then see, okay, well, what are we going to do about it? So I just want you to take back my journey in 2014, where I became a GP partner at a practice in a very deprived area with high rates of obesity and also diabetes and other cardiovascular disease deaths. And we took an initiative approach, and I must admit, I was having visited the primary care center yesterday at the Ali Al Ghanem, I hope I pronounced that right. I was very impressed because your infancy of setting up the primary care framework is so new. You're already like 30 years ahead, because it took me, I reckon about 5-6 years before I could appreciate the impact pharmacists can have. And I saw a consultation room at the center yesterday where I saw a pharmacist, and he was ready to conduct clinics for diabetic reviews or any types of medication reviews, which is brilliant. And this is something what we did in our practice back in 2016. So we set it up in 2015, and after about 2016, it was formally set up. And what we wanted to do is make sure everyone in the workforce in primary care are skilled up and trained up. Knowledge base is kept standard, and we used our reception staff as our navigators to educate patients when they come in. So things like booking in for 9 key care processes for the diabetes management and ensuring the blood tests are up to date, done every year. The nurses, the GPs, and of course the clinical pharmacists. And what we wanted to do is remodel all of this around the patient care. And once we did that, we thought, great, okay, we upskilled our clinical pharmacists to prescribe injectable diabetic drugs like insulin or GLP-1, and then she effectively ran the clinic. Then what happened afterwards was we noticed at that stage that the data showed for itself, and that was the national award, and the pharmacist is on the far left, who's incidentally also named Dina as well. And having picked that up, that became a drive for change in our own practice. So let's go back now. Let's think about the impact of obesity. So we know that obesity, there are many diseases manifest from it. But I'm sure, like you, and I'm guilty of this, we only have time to deal with the presenting complaint, which is often what the patient tells us. Sometimes the obesity is never even mentioned, even though it's staring us blatantly in the face. And even though we know all these other diseases associated with it, we have to ask ourselves, well, how do we solve this? How do we manage this? And just yesterday, as we saw in the clinic, we saw osteoporosis clinics being run once a week, as well as regular diabetic clinics. Could there be one for obesity, for instance? And so we're proactively now managing and highlighting to the patient that if we prevent this, we could potentially prevent these other disorders coming into play. So a very famous man once said, if you've got to understand the why, you have to spend a lot of time thinking about the problem itself. And one other advice, and I can't remember who it was now who had written this statement, but effectively never go to a negative person and ask for a solution. You'll always only end up getting more problems. So start to restructure it and start to spend 55 minutes thinking about the problem. So start looking at your own data. And if we go back, we know that the chemicals involved in rewarding us are these four, because now we're starting to deep why. Why is obesity so prevalent? And why is the incidence rate rising? And if we think about these four basic hormones, it becomes more transparent as to why this could potentially be causing an issue. So if we think about dopamine, a rewarding chemical, oxytocin, our love hormone, serotonin, and endorphin. And we know from an evolutionary aspect, it is in the best interest of humans to have an inherent desire for food for survival. However, this desire may go awry, and certain people, including some obese and bulimic patients as well, and I understand there's a talk later on about this, may develop an unhealthy dependence on palatable food that interferes with their well-being. The concept of food addiction is possibly something to think about. And what we do know is that if you think about the ventral tegmental area, where it secretes the dopamine, and it secretes the dopamine via the mesolimbic dopamine pathway and the mesocortical dopamine pathway. And your nucleus accumbens is responsible for, if you like, your emotion. But your prefrontal cortex is responsible for executive functions. And when you think about the reward circuit, it depends on the action of dopamine. Dopamine is synthesized and released by the neurons, as I mentioned, in the ventral tegmental area. And those two primary pathways are what's causing, if you like, a little bit of imbalance within the area. But then you have to ask yourself even why. Well, and this was the most interesting, impactful study, and I really commend Kuwait on this, that when I dug a bit deeper, I found this study published in 2019, where they started looking at the reasons for students consuming fast food. And what you could see here is that Shaban et al. Basically were saying that most people like the delicious taste of food. But the food industry knows this. And the food industry knows this, so foods are often laden with sugar and salt, some of the two key essential ingredients we need for life. But of course, gone haywire, it goes out of control. More importantly, this I found really interesting, was the students' belief about the nutritional value of fast food. So despite a lot of students knowing it's poor for them, they still consume it. Why? And of course, the students' fast food consumption throughout the week. We could say they're busy schedules, they don't have time. But if you look at the chart, you can see it's most consumed during the weekend. Why? We know that fast food is becoming a really rife thing globally, not just in Kuwait. But there is some element of the fast food being linked with patient behavior. And I'm thinking, if you want to implement strategies to combat the rise of obesity-related ailments, and by the way, you'll get no thanks from this from patients initially, because I've tried this. And it's a question of they don't perceive this as being a problem. And that's a problem. And if you don't prescribe something, I've often been told I'm not a true doctor. But I've been thinking that if you're prescribing change of behavior, that for me is a prescription. It's up to the patient now whether they accept or not. And we'll come on to strategies as to how we can encourage that further. So what you would really want is a surrounding framework. And again, it's your practice as well, which will come across to the supportive structures, but more the surrounding framework is based on the government policies and the national strategic campaigning. And this is where you can make sure that there is enough education, information out there for patients to seek further input. The supportive structures, so we're thinking about the families, the communities, and of course, engaging children, young people, so inviting them in to discuss about obesity more openly. So I read the Sustainable Development Goals #3 on there, at the Kuwait Voluntary National Review 2019. And it's very interesting when you see the Public Authority for Food and Nutrition has been initiated as of 2016, where you're decreasing the levels of sugar and salt in juices and snacks through community awareness programs. But in the practices, you can actually measure the change and measure the impact, because remember, they're visiting the primary care center the most. So thinking about some of the initiatives that's very prevalent throughout England anyway, where they're setting up good networks of practices, working with other practices, forming what we call PCN. So PCN is basically primary care networks. There's no reason why you can't to think about starting that already. Start building the trust, forge the relationships with the other local practices to support one another. And then, of course, you want specialized care. So some centers might be able to deliver that specialized care. And then think about secondary care at your tier 4 stage, where it's predominantly hospital-based. And I've often said that if you are struggling with this, there are some really good techniques out there. And one of the key ones I always recommend, you must read this book, is called Nudge, Thaler. If anything you take away from my talk, and I don't mind you saying your talk was not great, Jay, but go away and read this book. It's definitely worth it. And it's because of years of research that has been done, mainly on government policies in America, where you can look at nudge techniques, where you can nudge change of behavior, not only in patients, but colleagues. And dare I say, if you wanted a pay rise from your boss, this could also work as well. So you've got to think about the incentives. So what does it stand for? So the nudges, as Thaler described it, was that the N is incentives. Now, I appreciate it begins with the letter I, but I think they accentuate the N here. Understanding, mapping, defaults, give feedback, expect error, learn from mistakes. And this is where collaborative working could be very advantageous. You'll learn from other people's mistakes so you can prevent, strategize, and improve. If you make a mistake, you then share that learning with another colleague. And of course, structure your complex choices. How many times have you been in a clinic to say to a patient, would you like to start metformin? And then after metformin, I need to put you on a statin. After the statin, I then need you to go and do a blood test. In 3 months for your diabetes check, and then a month for your liver test to check that the statin hasn't impacted your liver significantly. As a patient, I wouldn't know what you're talking about. So structure the complex choices. Prioritize. Nowadays, I spend more of my time not issuing prescriptions, but more issuing advice and changes. And I assure you that in the long-term strategy, that's more likely to develop more impact than it will from the immediate prescriptions. And don't forget, prescriptions are costly for everyone. So why? So the nudge technique by Thaler is often associated within the field of behavioral economics. And it's true, money does talk. So it's a concept designed to subtly influence the decisions and behaviors of individuals without restricting their freedom of choice. And once you finish this book, there's another book he's written called Misbehaving, which is another really good book I would recommend you read. So if anything, again, I'd want you to think about the preventative action in the family practice. And what can you do? I assure you that if you use the nudge techniques with your patients, it will pay out significant dividends. And I think it's about time we started changing the behavior about ourselves. So thinking about asking patients about their dietary habits, the fluid status. So how much water do they simply drink compared to fizzy drinks? Of course, the exercise, sleep, mental health and well-being. And can I, if you don't mind, I wouldn't mind doing a very short poll. Can you, I think we're okay for time. Can you show me can you raise your hands to let me know how many of you ask about sleep with your patients? Brilliant, Well, I tell you one thing, you're already far ahead of me on this one. I had to change my own practice to start thinking about sleep. So I make it mandatory now that in my consultations, I'm asking these 5 steps, which is great. And of course, prevention is always better than cure. And failing all of that, if we had to, there's always the drug Wegovy. Now, it's made headlines because it's just been approved for adolescents over 12 years and older with an initial BMI at the 95th percentile for age and sex, along with diet and exercise. Why are we prioritizing a drug before diet and exercise? And that's my only take home, is that this is not a magic bullet. And Wegovy, you'll start to get asked questions potentially from patients. And it will be interesting. It won't be because of what you think they're asking for it. It'll be more about perceptions. How do people view their body habitus? One of the, I think we've got time, so I might just talk about a project we're working on with the hospital. And here, what we just show is that your data sets, please, if anything you learn from our mistake, and I've spoken to one of the largest IT providers in England about this, is we never valued data early on. So what I mean by that, in the 1980s, when the clinical IT systems were being developed, the data structures were very haphazard. So what we wanted to try and do is get the data to yield more benefit for us and for patients. So start to think about your own clinical IT systems and how you can use data to then review patients that are likely to be likely to have obesity and who are at the tipping point of obesity to potentially prediabetes, developing prediabetes or diabetes or other cardiovascular deaths. Other cardiovascular diseases. So start thinking early. And so once you know that data set, you can then identify and review, as is shown in step 1. And step 2, you can contact and book them proactively. And I commend the medical students' usage as well. It's good use of resources. It shows them empowerment, and you're also training and nudging their behavior to think about behavioral change. And then step 3, of course, is collect the key biometric data. And that's going to be your foundational tool to then help patients move along on that side. So if anything, the key takeaway points I'd like to share is audit your population, contact them, engage in early weight loss and management plans, track and monitor, and make them an ambassador of good health, which will then have a ripple effect amongst their own communities on that side. Thank you.
Thank you. So, any questions? No questions? So we can proceed to the next lecture. Thank you.
So the second lecture actually is very much stems from the first. And one of the things we wanted to understand is some understanding adolescent behavior. So some of the unique challenges and opportunities of adolescents in primary healthcare centers. So again, the aim is to have an overview of the current challenges amongst adolescents and discuss how primary care can make a difference. Want to be able to identify patients who might have mental health issues and influence behavioral change among those patients so we could nudge their mental health state to a different level. And of course, this is where it's very essential to deploy lifestyle medicine to improve mental health. So again, this was a study that involved 2,428 students aged between 15 and 18 from the secondary schools in Kuwait's Ahmadi Governorate, examining their health-related interests and discussions with physicians. It's rather old, 2012, but I think you'll find this is quite pervasive, even in England, I would have thought. Although, interesting enough, I struggled to find some data in England about this. And one of the key things that it highlighted was how healthy nutrition is right at the top there, with a decent statistical significance between the healthy nutritional values and the impact of physical activity being at the top there. But then more importantly, in the blue segment, where smoking, drug addiction, anxiety and depression is also quite high up on the list. But what's really interesting is the bottom part, the subjects that were actually discussed with the physician. And you see the numbers actually are a lot lower, and you see that better on this slideshow here, where you can see the proportion of adolescents actually discussed health-related issues with physicians among those who wanted to talk about it. And you can see where addiction, anxiety, and depression are not quite high up there. But things like nutritional and body weight, which is interesting, they do want to discuss that for sure. But what's really important to understand is, where are they getting this information from? And we often think it could be down to social media. And bearing in mind, 2012, at that time, Facebook were pretty popular, as were other social media platforms. So you've got to understand where they're getting this information from. And only once you understand where the information is coming from, you can start to think as to where this could be, where you can make the most impact. So you can see the sources, of course, is very commonly the father. And it could be because the patriarch in the family is often the go-to person for things like this. Mother, of course, and sisters and brothers, and so forth. And what we were thinking is this potentially where the trust and judgment is most helpful in this regard? And one of the other things that you really got to understand about adolescent behavior is, are the two things linked? So when we're thinking about the mental health side of things and the nutritional intake value they get from food, is what are the links and what are the environmental influences on mental health? So this was a Bugs and Brains, the Gut and Mental Health study. It was a mixed method study investigating microbiota composition and function in anxiety, depression, and irritable bowel syndrome. So how many times you get an abdominal pain coming through your clinic and you're thinking, well, all the tests are normal, but I have no idea what's wrong with you. So you start to dig deeper and think about the brain as a second organ in this regard, in the sense of the second brain in particular. And this just shows an illustration how some of the immune pathways, the neural pathways, and the endocrine pathways can actually impact the central nervous system more so, even though the gut, being the autonomic nervous system, is there, but what you're consuming in terms of food, so some of the, what we call the inflammatory chemicals, which they add in as some of the additives that they add in drinks and fast food joints, could be something worthwhile noting. But once you understand this psyche, it becomes very helpful to then start asking more about, well, you're talking to me about anxiety. Why do you care what I'm drinking at nighttime, like a can of Coke or Pepsi? Well, it does. You're going to get lack of sleep. You're inducing yourself with other additives in your body which you may not need. So think differently and behave differently accordingly. And so when we think about it, we think about how is this culminating with the whole obesity, type 2 diabetes, and hypertension? And I think of it like this. If you imagine like the platform is your insulin resistance and dyslipidemia. And one of the other things they've said is the inflammatory section of this, which promotes what we call the metabolic syndrome. So one of the key changes we've done in our practice is we're going to get rid of our diabetes clinic. And what we've done is we've partnered with the local hospital to set up what we call a cardio-renal metabolic clinic. So it's starting to practice more holistically. So we contacted the consultant cardiologist at the hospital, the consultant endocrinologist, and of course, the lead GPs and our pharmacist as well. And we're now running these workshops to have basically what we call a CRM clinic now. So no more diabetes clinic. What we found was that consultants are fantastic, but they have a niche. So I have a consultant cardiologist say, stop this drug. I have a renal physician who says, stop this drug. But who's asked what the patient needs? So it's up to the primary care physician to then start to put this composition, the building blocks, put the patient in the middle, and work what's best for the patient in terms of not only longevity, but also quality of living. And then you look at the modifiable risk factors: diet, exercise, alcohol, smoking. And then we hope that by combating the yellow stream here, we prevent what's in the red at the top, which is your non-alcoholic steatohepatitis, coronary arterial disease, chronic kidney disease, peripheral arterial disease, stroke, cancer, and dementia. But again, if we're going to do all this, great, but where do we start? Again, go back to the 4 chemicals. Start thinking along these lines. How is the patient rewarding him or herself and then triggering into the spiral that they're having difficulty to come out of? So if you can understand what the levers are that's helping them facilitate the release of dopamine, it helps. And if we've got to go back even further, again, go back to the brain, go back to the neural wiring. For tens of thousands of years, we've developed with the same mentality on this. So start thinking, what is triggering this dopamine release in the nucleus accumbens and in the prefrontal cortex? And once we understand that, we think, okay, we might be able to do something differently. And of course, we know the reward element. So some drugs target the brain's pleasure center. And that's the whole point, is sugar is just as like a drug. The only difference is it's been legalized, whereas you think of it, illicit drugs or illegal drugs, of course, they also work on a similar pathway. It's no different. And of course, what it comes to, and I hope to share with you in a minute as to how you can use strategies to try to mitigate this. So the natural rewards that increase survival and fitness of the species activate the reward circuit. And these behaviors and stimuli include certain food and those high sugar and fat levels, social bonding, parental bonding. And most drugs of abuse also activate the same reward-based learning mechanism. And so when you think about it, what is this repetition of this cycle we create habit from? We have a reward trigger. We have the trigger, of course, then it changes the behavior, and then you have the reward. And again, I will come across this other fascinating, and this is very, very important, because if you're thinking about, and we talked on this yesterday in Dr. Whittle's talk about machine learning and artificial intelligence, it's very similar, because we also do some work in this, probably not as a grand of a scale, but in a small scale. And if you're training machines to learn, you can reward the machines as well. And it's very similarly with humans. You can reward them with certain influences. I actually do this with my 10-year-old son now. So we reward him with star charts. And when we reward him, I can nudge him and influence behavioral change. So often the trigger would be he's done something good. His behavior is then acknowledged, and he then gets a reward in the form of a star chart. He accumulates a certain amount of stars, he reaches a certain level in which he gets a bigger prize. So I'm not trying to say that you're going to become master manipulators on this, because that's not the aim of this. But the aim is, effectively, is that you to think about what nudging techniques you can use to help influence change. And remember that addiction is a continued use of anything, not just drugs. So addiction is the continued use despite adverse consequences. And this is what we see in patients with bulimia, with patients with even obesity. It's all linked. And why is addiction so common? And a very famous clinical psychologist, and I'll mention his name in a minute, is because they believe it's due to convenience and efficiency. Your iPhone, how many times do you touch your iPhone and look at it? And I dare you to do this as an exercise one day. Just measure it. And you'll see you become addicted. And you'll see certain parental behavioral changes. I've seen it in my own clinic, doing a family clinic. I'm doing a neonatal exam, and the father and mother on their iPhones each. And I'm thinking, oh my gosh. Normally, if you rewind back, we're thinking a predate iPhone in its extremities. I'd be asking mother, saying, oh, is that normal, that rash over there? Oh, the skin's very dry there. Shall we do something about that? None of that. It's all on the iPhone. I do my job. And I guess they do theirs. And that's it. Clinic finished. And you're thinking, where is this going? It's as if we're mindlessly walking towards this zone where social isolation is going to be even worse of a problem as we go around because we're so addicted to our own phones. And don't worry, I am very much a hypocrite here because I too am like that. But I'm trying my best to nudge my behavior. So when I go on holiday, I make sure I switch off my phone in the sense of I don't get any emails alerts. I switch off my data on there. So I'm there fully present with the children and with the family. And so doing these techniques, even when you saw on the earlier slide about the father being the most trusted source adolescents go to, start thinking if you could link the two together, that the next time the father comes into your clinical room, or the mother or sister or brother, whomever, is you using these nudging techniques on them to make them mindfully aware can potentially have significant impact. But often patients say, why can't I change? And yet, again, it comes down to the reward-based learning system. Our brain acts on impulse and works on a reward-based learning. And habits form to make it easier for us to function. Evolutionary process for survival purposes, and the prefrontal cortex is learning and developing and needs to store repetitive functions for autonomous purposes. So because your brain has to work hard every time it has to think about what to do differently. So it's far easier for it to think, okay, I'll just do this in automatic fashion. And once you're hooked on that cycle, then it becomes very difficult to get out of. That's the book I was mentioning, by the way. Fascinating Learning. And if you want to understand technology and humans, that's the book to go to. So Google did this with DeepMind. So when they trained one of the machine learning models, they had to understand how do babies, then children, then adolescents, and then adult humans learn. Once you understand the neural pathways of learning, you can then trigger machines to do the similar sort of pattern. So Google used DeepMind with reward-based learning. It would give it a reward, if you like, for every time the machine got it right. So the machine then learned that, okay, I need to keep learning to get this reward element. And it covers it in the book. I had to read it twice, by the way, because the first time I read it, it was way over my head. And then the second time I read it, I started to understand where it was coming from. But if you want to do all this, you've got to understand also the cycle of change. I also use this in my own clinics now, that for smoking, stop smoking cessation, if a patient's in the pre-contemplation stage, I don't even bother. And we have GP registrars in our practice, and physician associates. We're about to have GP registrars. And they would say, oh, you never mentioned that they should stop smoking. I said, but I asked them that, have they thought about stop smoking? And the patient says, no. So I can talk till the cows come home. I'm never going to change this person. So there's no need for me to delve deeper. But the minute a patient says, yeah, my mother passed away the other day from a stroke, that's my hook. And that's my trigger. And then my cue to change their behavior and then eventually reward that behavior. And that's when I would say, have you thought about stopping smoking? Why do you think the stroke happened? Oh, I think it's because she had hypertension. Why do you think she had hypertension? Oh, I think she didn't exercise much, didn't look after her diet, and also smoked. I said, smoking. Thought about quitting. Maybe. Okay, well, let's carry this on discussion at the next time. Understanding the cycle of change really helps to empower you more, possibly, than the patient. But it allows you to then know when to tap into that mindset or the psyche of the patient. And the other thing, of course, you have to worry about is the addiction maximizers. So these are intermittent reinforcements. So think about like this. Casinos in America, in Las Vegas, and it's great, there's an experiment done on this. They've programmed the slot machines that will keep the person gambling, and then they'll reward them at the minute they're about to start thinking, I'm giving up. And the reason why is, and if you think about it, it's the same as if someone threw you a surprise birthday party. You weren't expecting it, but you loved every minute of it. It's that surprise, that winning, because it releases the dopamine. And, you know, tech companies in Silicon Valley have this programmed so well that even your alert notifications, the minute you get a ping, you pick up your iPhone straight away, as if it's autonomous. Not, actually, hang on, I'll pick up the phone in a minute. And so the trick is basically turn off your notifications. And of course, immediate availability, time. Time is so critical in our fast-paced lives. And we just instantly order. Think about the Deliveroo app, if you have that, or Uber. How quickly is it to order something, get it right now? And that's why I was hearing yesterday at the primary care center, is that when patients were, you know, challenging your reception staff, it was because the patients want to be seen right now, dealt with right this instant. It's because they've been programmed that I can get everything else instantly. Why can't I get my healthcare the same way? And medicine, unfortunately, sometimes lags behind the technology companies and the fast food industry. But it's time for us to change and pick up that pace. So what can you do about it? So think about anti-addiction strategies. Willpower. It's great for short term, but maybe not so in the long term. And I must say, last night's dinner event really tested my willpower. Lovely food, gorgeous food, amazing food, great hospitality, brilliant experience. But I had to fight really hard to say, I cannot take one more bite because this will be dangerous for me. And it's very hard. And you can't sustain willpower all the time. It's very easy for us as clinicians to say, patients, stop eating that. Hang on, that ain't going to work. You've got to try something else. You could substitute behavior. So if you're craving for A, you do B instead. So I've done this myself. Thanks to you, mainly because I was researching this and I thought, well, I've got to practice what I preach here. So I've now swapped a lot of fizzy drinks with water. And so I've substituted. And I try to now mentally trying to pre-program myself to say I reward myself every time I drink water by saying, well done, good job. But don't worry, I don't say out loud, it's internally. Otherwise, I'm sure you'll be thinking me at the dinner table, what am I on about? And think about the anti-addiction strategies. Prime your environment, so avoid potential triggers in view. So ice cream in the freezer, or placing trainers near your bed so you go for a run. And I say this to patients as well, that, you know, think about, you want to exercise, you want to go for a walk, put the trainers right next to your bed. So when you wake up, you see it there. You go for a walk. 5 minutes, fine, no problem. Do it for 2 minutes, but do something. Start. Often the hardest part is initiating. But once you initiate, it becomes easier. Then it's maintaining consistency. Mindfulness is the, if anything, again, from this particular talk, is take away the mindfulness. The Japanese have a really good philosophy of ikigai. Ikigai is basically where you have a sense of purpose. If you have a sense of purpose, they found people in Okinawa were living up to about 100 years of age. Healthy, fit, mind sharp, but they practice ikigai. So it's a different mentality to the, you know, in terms of Western world way of thinking of retirement age, and that's it. And then I've had people say, well, what do I do now? I don't know anything. All I know is work. So maintaining that ikigai and always trying to center yourself and thinking I have a sense of fulfillment and purpose. It also is great for social isolation because it feels they have a purpose to do something. And I often practice this with my patients, is the mindfulness aspect. And John Kabat is an American physician who said the awareness that arises when paying attention in the present moment on purpose and non-judgmentally. And if you can practice mindfulness, not only with your adults, but also with adolescents, it really works. Even with children, it really works. So trying to encourage them. And how you're thinking about doing that is you've got to think about the pyramid structure where you have the curiosity. Well, first of all, you've got to have the curiosity, you've got to have the awareness, and then eventually the change of the habit will occur. And believe it or not, it all will help if we go back to this. Ask about the dietary habits, ask about the fluid status, ask about the exercise, ask about the sleep, and more importantly, I always say, is ask about the mental health and well-being, which is so prevalent in adolescence in terms of mental health illnesses. It will be crucial to do. So in summary, what would you take away? Appreciate sugar addiction is on the rise, and it is. You've seen it from the last 2 talks. So ask about dietary habits. Practice mindfulness. It's worth it. And if you're not sure where to go, I would definitely search up John Kabat-Zinn a book. He's written a couple of books on this topic. So encourage patients to think about the impact of lifestyle consequences can have on them. So I've often said, if you're in a clinic and you say to a patient, oh, you've got to stop drinking, oh, you've got to stop smoking, it's not good for your health, you're going to get cardiovascular disease, your risk of mortality rate is whatever percentage, it doesn't mean jack. It does not mean anything. But if you phrase it differently, again, nudging techniques, and say, did you know your son is 8? Would you like to see your son till they go to university? Or would you like to see your son have children of their own? Oh, but you may not be alive until then, because your risk of having these conditions can impact your health. I didn't know that, doctor. What do I do? So learning and changing the way your words can be impactful. Words have power. It started wars, after all. It's the same thing here. Words have that power. So think about the wording you use with your patients. Prescribe less and ask more about lifestyle questions is the one I've taken away the most from it all. And I saw this very funny clip that I thought you might like. I don't know if you've seen it, but I find this so true. And if your doctor prescribes you medication without first asking about your diet, sleep, exercise, water consumption, and the stress, which is the mental health, then you more likely have a drug dealer on your hands, but a legalized one. So just bear that in mind every time you prescribe. And don't get me wrong, I'm not saying never prescribe. What I'm trying to say is just prescribe mindfully, being aware. That's it. Thank you.
Thank you very much, Dr. Verma. We have a few questions.
Okay.
What are the main challenges facing physicians when coming to adolescents' mental health care? And what about parental consent to medical therapy? Is there any limitation?
Yeah, it's a great question. You know, the biggest challenge I have in my working clinic is the barrier to accept and the barrier to engage. And I'm afraid I have no quick answer for it, other than look at the triggers and examine the triggers. And the more you delve deeper into this, and this is a question that I'm going to ask on the back of this question, is that if you start to, you need time. And I appreciate that your clinics are very busy. You have 10 minutes. How are you going to do this? Because we struggle. So I'm a big believer, and I think you guys are so brilliant and bright and way ahead of the game about sick note strategies. I mean, you're only, thinking about the infancy of primary care where you're at, and you're thinking about it. But what you're doing is you're creating capacity by addressing the sick notes in a different means. When you have more time for your patients. And I think having those strategies, that's why, so with adolescents, you cannot do this in 10 minutes. I normally have my clinics where, and I was speaking to Dr. Moley earlier on, and we also said that we now give when we triage our patients, we give them half an hour. Time is the most important. And then you can address those barriers to change and barriers to acceptance accordingly. And then if the father's in there in the room, or the mother or the family, then it's engaging them as a whole is more likely to be impactful. Because you saw the earlier slide, the the adolescents tend to trust their father or mother the most. So that's what I say. So I think building the trust relationship But in doing that, you need time. So in doing that, you need to address your sick notes. If it's 30 to 40% you're coming through, and I think e-consult's great on that side. So I think that will help mitigate some of those barriers. It will help you create time to address those.
Thank you. There is another question. Somebody's asking about Wegovy, and is it safe for adolescents with BMI above 40, and how is it when compared with bariatric surgery and other dietary advice?
Yeah, it's a good question. So one of the key things is when you swear the Hippocratic Oath, it's about do no harm. And I often think bariatric surgery, I think there's a need where you've got a patient that's at the metabolic disease stage, they've got a trifecta, so they've got the type 2 diabetes, they've got cardiovascular disease, and they've got kidney disease and whatever other organ that's an issue. Then that's the stage where we would think about bariatric surgery. But if the patient is, say, morbidly obese, but they are not having any of those pre-metabolic conditions starting yet, then I would definitely more likely to enforce the diet and lifestyle and the hooks and changes. But the minute they're tipping over, where the biomarkers are starting to show they're tipping over to the metabolic state, then I'm worried. That's when I think bariatric surgery or Wegovy. And Wegovy, although it's been licensed in children over 12, I'm just thinking, what are we doing? Is that the right way of practicing medicine? Sticking injections? Because there are other techniques. The question is do the risks outweigh the benefits? And that's purely your own judgment call on this. So no hard and fast rule. The law will tell you to do one thing, but whether you do it or not is your prerogative.
Another quick question. How would you approach giving advice to adolescents with obesity? Should we target the whole family?
I think it's a fantastic question. I think you're spot on. Because who does the cooking? In our diabetic clinics, we used to have the patient, often the men, coming in our diabetic clinic telling them that you need to reduce your sugar levels and you need to do X, Y, and Z. We were failing miserably. So when just prior to winning that award, what we did was we flipped it. We started inviting the wife into the clinics. And the husband and wife would be there and would explain. And this is where I think women, I'm sorry, men, are highly more intelligible than men. The women understood it, they got it, and they started preparing food programs within the house, and very militant-wise. I don't want my children to have that. I don't want my husband to have these illnesses. I will do it. That's when we saw the biomarkers of the patients starting to change. So indirectly targeting, and I think a family approach is a fantastic approach because they also motivate one another as well. So definitely family. And we're family physicians, right? So family physicians practice family medicine.
Thank you so much. There are lots of questions, but because of the time, we apologize for that.
Sorry.
Thank you so much.
Thank you. Shukran.
We are just inviting Dr. Edina for the Guggenheim Trophy.
It's a great pleasure to introduce my role model and trainer, Dr. Alia Sadiq. She's a consultant and head of Mansouriya Clinic. She's the head of Child and Adolescents Care Committee. She is a trainer and examiner in Kuwait Family Medicine Board. She will be talking about child health and primary health care, the bright future. Dr. Alia, the floor is yours.
Thank you. Good morning, everybody. My name is Dr. Alia Sadiq. I'm going to discuss the Will Baby Clinic and the journey of it in Kuwait. So, at the beginning, Thomas Edison, he mentioned that the doctor of the future will give no medicine, but he will interest his patient in the care of a human frame. And the diet, cause, and the prevention of disease. In 2013, the WHO raises the importance of family physician. They mentioned that the health system, where primary health care is the backbone and the family physician are the bedrock, deliver the greatest health outcome with the lowest cost and greater user satisfaction. The primary health care is the best hope for the future, and the family physician are the racing star for the future. Why? Because we are the person who deliver the prevention. And this is the most important part. We discussed during the previous 2 days about the big revolution that happened in the availability of medication for chronic diseases. But still, we have a high rate of morbidity and mortality. So the best way to avoid the problems and to treat the chronic disease is to avoid it from the beginning. And this will happen by prevention, by screening. So primary health care in Kuwait aim to provide an integrated and high quality of health service. And we are aware that one of the most important way to deliver the health service is to provide prevention. And this will happen by health education, by increase the patient awareness, by early detection and screening for diseases with early intervention. And accordingly, the idea of Well Baby Clinic works to promote the idea of prevention. Do we need Well Baby Clinic in Kuwait? Okay, so Dr. Anwar, she's supporting. Why? I will discuss some of the topics and important topics for pediatrics that we already share it international with, international statistics. WHO, the last fact sheet about obesity and overweight, which was in 2021, the worldwide obesity is nearly tripled since 1975. And almost we can see that half of the population in 2016 are overweight and obese. Most of the world's population live in countries where overweight and obesity kills people more than underweight. And we have a lot. We have millions of children who are less than 5 and millions of children from age 5 to 19 who are overweight and obese. The obesity is preventable. Yes, we agree it's difficult, but we can prevent it. So the childhood obesity, it's a epidemic problem. Progressive, and I will show you in the next study what I mean by progressive. It affects the development of the child, the physical development, emotional, psychosocial development. It causes chronic disease and increase the morbidity and mortality. So what's the statistic in Kuwait? According to the Kuwaiti Nutritional Surveillance, the obesity and overweight for children in 2019, it was 8.3, and 2020, 11.9. For the next age group, 2 to 5, at 2010 we have 6.1%, 2019 we have 8.9%, and in 2020 we have 11.3, and we can see that the number doubled in the 10 years. The obesity in the adult population in Kuwait for overweight and obesity, almost 75, which is a significant number. Almost 3/4 of our population are overweight and obese. So imagine the chronic diseases that we will develop. So we are in the top ranked countries in the obesity, not only in the top rank, but we are one of the most fastest country in developing obesity. So I mentioned in my previous slide that obesity is progressive. A meta-analysis and systemic review make to predict obesity, adult obesity from childhood obesity. And the result was that 50% of children who are obese will grow as obese adolescents. 80% of the obese adolescents will become obese adult, and 70% will remain as obese at the age of 30. So these are significant numbers. What's the plan for WHO to stop the obesity? First, the aim to halt the rate of obesity for children under 5 and adolescents, and this is by encouraging the breastfeeding and improve the lifestyle with reducing physical inactivity, and mainly to increase the cover in primary health care with the prevention, diagnosis, and management for children and adolescents. So the age group that the WHO insists to take care is to take care for children less than 5, 5 to 3, and adolescents. So not only to treat the adult for obesity. So do we only talk about obesity in Well Baby Clinic? No, we have a lot of problems. We do screen for a lot of chronic disease, a lot of diseases for children. One of them, the developmental dislocation of hip. We have significant number, but I couldn't find the statistic in Kuwait, but I find a close study which was done in United Arab Emirates, a population of 145 neonates were taken. 47% were from the GCC country and 53 from other countries. The rate of child with developmental dislocation of hip was 2.9 for GCC country and 0.5 for other countries, which is significant and can be treated as soon as possible with minimal complication in future. We also do screening for hernias, for foot problem, and developmental problem that we agree that is significant and rising worldwide, such as hearing problem, developmental delay, ADHD, and autistic child, so we can screen as soon as possible and interfere as early stage with education for the parents how to manage. So, what's the Well Baby Clinic? The idea of the Well Baby Clinic, it's a primary healthcare clinic, specialized, aimed to give a prevention for healthy child. The age group, less than 5, and we aim to create a better world for children in Kuwait by advancing health and well-being. So as I mentioned, our target group, less than 5, healthy child, the medical staff regularly monitor the child for their growth, for their physical growth, for the developmental parameters, and all of this will done in a periodically monthly assessment during the first 2 years, then annually till age of 5. We don't only do the physical assessment and developmental parameter, but it's the clinic that aim to give parental advices and increase the education for the parents how to deal with their children, increase their awareness about breastfeeding, obesity, nutritional problem, the safety, and check the immunization of the child, address the parent day by day concern, advices about the behavior, the common behavioral problem of the child, such as temper tantrum, how to deal with the sleeping difficulty, picky eater in the children. So we do a periodic evaluation for the child, check the physical growth. Mainly we assess the weight, the height, the BMI, plot it in the growth chart, discuss it with the parents, do the developmental growth, check the motor, emotional, social development, and conduct the tests that are important for each age group as a screening. We mentioned that we give education, health education to the parents, deal with the misconception. As the previous lecture, the source of information we take mainly from the family, so the best target group to educate the parents about the appropriate health education. What are we doing as a committee in a primary health care? We do guidelines and protocols for the Well Baby Clinic. We make operational policy, how to run the clinic. A lot of workshops. The workshops aim to educate the doctors how to run an ideal Well Baby clinic. Field training after training in the workshop. And finally, we do a periodic evaluation for the clinics. So the journey started in 2005, where the first guideline of the Well Baby Clinic were published. Then there were 2 clinics in each governorate. After that, in 2013, an update for the guideline was published, and in the same time, there were the first Well Baby Clinic ideal Well Baby Clinic workshop introduced, and then this workshop has been done frequently. The page of the Well Baby Clinic, I can show you that whenever a child who's less than 5 present to the clinic, directly we assess the prenatal history in the first visit. Then we take the measurement. The first thing to assess if there is any parental concern. If yes, it will be written. Then we go for the growth measurements, weight, height, BMI, and hair circumference. Then it's directly will be plotted in the growth charts. Assessing the development of the baby, gross motor, fine motor, hearing and speech, cognitive, social development, nutrition, education advices, and physical examination for each group. And if there is any future plan, then directly the measurement which is taken will be plotted in the growth chart so the doctor he can discuss with the parents about their child's physical growth. The Ideal Well Baby Clinic workshop, we have it averaged twice per year. It's covering the protocol, covering the operational policy, and train the doctors how to use the growth charts and how to interpret on it. Our clinic in Kuwait, since 2014, we have a 12.7, and now today we have 83% of clinic in Kuwait have Well Baby Clinic, and within next few months, all of the clinic in Kuwait will have a trained doctor and Well Baby Clinic there. All of the trained doctor in the workshop will have a field training in their governorate. In Capital and Ahmadi, we didn't reach to the percentage because this statistic was till November, but at the end of this year, at the end of this month, all of the doctors will be 100% trained. In addition, since 2022, in the curriculum of Family Medicine Residency Program Board, the workshop has been introduced in their curriculum in R5, and last year already we trained 42 doctors. We make a collaboration. We mentioned at the beginning that one of the most important is to interfere with early feeding in children. So we have a collaboration with Administration of Food and Nutrition in Kuwait, and we held 4 workshops about infant and young feeding counseling workshop. It's a workshop of 5 days with 2 days training in the maternity, education about the feeding and dealing with mothers how to give advices for breastfeeding. And already the training were last year 56 doctors. We have 13 breastfeeding counseling clinic in Kuwait. In the Well Baby Clinic, we have quality indicators. We are assessing the number of children who are less than 5 and we are assessing the child who are less than 5 following the clinic. Measuring the normal weight to height ratio, which indicate that the Z-score between -2 and 2, the child with normal BMI who are presented to the Well Baby Clinic, again, the normal BMI Z-score between -2 and 2. And finally, we assess the number and the percentage of referral to the secondary care. And as I mentioned in the beginning, the child present as a healthy child to the clinic with no any complaint, just to take advices. And by early screening, some of the doctors find a significant and important thing that we have to investigate. So you can see that last year, we have a referral for secondary for a suspicious of diseases. So now we finish from where we are, where we want to be. So we want to expand the service, and within few months, we'll have all the clinic in Kuwait covered with Well Baby Clinic. But we don't want to stop here. We want to empower the prevention and screening concept. How and why? We have the school age and we have the adolescents, and we all agree that the adolescents are one of most challenging and difficult age group, and they need a very strong rubber to build with them. So we think that since we established the Well Baby Clinic as a screening and preventive clinic, why not to continue with this age group since it's already established and the rabbit was built? Okay, we have a good school health, but the school health we have it's not expanded at the level of clinic. We have a clinic in each areas, so we are easy access. We already have a good rapport with our patient, so why not to continue the prevention and screening work? So what we are working now, we are working in a guideline for age from 5 till 13. We already have the guideline for adolescents. We are working at the operational policy, and by the end of 2024, we'll have 2 lectures about how to run and how to deal with this 2 age group. So we'll make sure that 40% of the doctors in Well Baby Clinic will be trained for this age group. And at the end of my talk, I would like to share with you a video which was taken on one of our ideal clinics in Kuwait. And I would like to thank Slabikhat Center for permission to take the video, and with Dr. Ahmed who make the video for me. Thank you. I'm done.
Thank you, Dr. Alia, for sharing your experience. Now we will move to audience questions. We have a couple of questions. The first question, You talked about training doctors. What about training the nurses?
Yeah, we already at the beginning, we have a training for the nurse, but with the shortage of the nursing staff, it was difficult to work after the COVID for their training. Then it's already the doctor who's trained in the Well Baby Clinic will train the nurse on the measurements of how to take a growth chart and etc. And in addition, in the next year, we'll have, with a collaboration with Food and Nutrition Administration, there will be a training for the nurse and health educator about breastfeeding.
The second question, what are the obstacles you faced when establishing Well Baby clinics in Kuwait?
See, the prevention, usually the people has difficult to go, they visit the clinic when they are sick. So the concept for prevention and screening is not that significant. They are not seeking health very frequent for it. So what I'm planning to, and what I wish that we increase the media and empower the media influence for the Well Baby Clinic.
So I guess you answered the third question, which is how do you encourage population to benefit from your marvelous clinic?
Yeah, we need the media. We need the media. Yes.
Thank you, Dr. Alia, for your great lecture.
Thank you.
Please accept our trophy of appreciation.
Hello, I'm honored to present our third lecturer for today, Dr. Maryam Al-Awadi. Dr. Maryam Al-Awadi is an assistant professor of psychiatry at the Faculty of Medicine, Kuwait University. She is an educator for undergraduate medical students and postgraduate psychiatric residents. She is a fellow of the Royal College of Physicians of Canada. She was the head of consultation liaison in Kuwait Mental Health Hospital and also served as the medical lead for the Women's Mental Health Unit at the Maternity Hospital and Psychosocial Oncology Unit in Kuwait Cancer Control Center. She is the only psychiatrist with a rare specialty in women's mental health and interest in issues related to mental distress in women across the lifespan. She will be presenting today Eating Disorder, Skinny Yet Unhappy lecture. Dr. Maryam, it's a pleasure to have you here. Please, you can
Thank you.
start.
Thank you very much. Thank you. Good morning, everyone. Oh, thank you so much for the invitation and giving me the chance to be part of this great conference. I'm very impressed with the attendance, mashallah, this morning for a Friday morning, very impressive. I hope that my lecture today would be beneficial to all of you. Before I start, I'd like to always appreciate the collaboration that happens between family medicine, primary care, and other specialties. And I can speak specifically on behalf of mental health, because about 10 years ago, we collaborated to do a collaboration between family medicine and mental health in establishing what we have now, thankfully, in all polyclinics, which are mental health clinics, as you know. So such collaborations, I know, are all to the benefit of patients, because in my opinion, family doctors are the gatekeepers. In my opinion, family doctors are the first people to receive patients, and therefore, after you guys receive them and assess them, you will determine where to take them from there. So your assessment is always vital, and such speeches or such talks, I think, are very relevant to people outside of my specialty, because you see these patients before we see them. Today's talk is about eating disorders, and as you know, eating disorders are many, but I'll focus specifically on anorexia nervosa, and that's the one I'll be talking about today. I'll start with a clip, and apologies to those who are only English speakers, but this clip is coming from one of my patients who I've interviewed, and she is a patient of anorexia nervosa, to give you a sense of what is this disease about, and then we can take it from there. أضغط play. Just click on it.
بعدين صار البانشمنت نوع ثاني، لأن أهلي تدخلوا بالأكل، صرت آكل أكثر من لما هم ما يتدخلون. فقمت لما يغصبوني آكل، وصارت في أيام أنغصب آكل، قمت أجرح نفسي. يعني دشيت، وهذه واحدة من أوضح ساينز الأنوركسيا. كنت correct me if I'm wrong. كنت أي وقت I eat أكثر من لازم بدون ما أحس أجرح نفسي. متى أستوعب أن أنا جرحت نفسي؟ لما أشوف blood، يعني
حتى ما تستوعبين
ما أستوعب
شيء أوتوماتيك
عليك نور. يعني حتى ما أحس بالبين. وايد مرات خذيت انتيبيوتكس لأن كانوا الجروح تلتهب. كانت ترتفع درجة حرارتي، أضطر إني أخذ انتيبيوتكس.
Okay, thank you.
بعدين صار البانشمنت نوع ثاني، لأن أهلي بعدين صار البانشمنت نوع.
Okay, perfect. So this was just a clip and from a podcast that I did back in 2021. And during that interview, it was about a patient's real experience with anorexia nervosa. So I wanted to give you a sense of how patients with anorexia nervosa can reach a point of even self-harm, suicidal thinking, due to their comorbid depressive symptoms, which we'll discuss, of course, further. So eating disorders, of course, they're characterized by a persistence, and the core feature of eating disorders in general, that they have a persistent disturbance of eating behavior that leads to impairing their health and overall psychosocial functioning. This is something that all eating disorders share. What are the eating disorders, or what are the different types of eating disorders in the DSM-5? Anorexia nervosa, which I'll be focusing on today. Avoidant and restrictive food intake disorder, which I'll explain what's the difference between this and anorexia. Binge eating disorder, bulimia, otherwise specified eating disorders, pica, and rumination disorders. These are the 7 main specified eating disorders in the DSM-5. Okay, let's talk about epidemiology in general of eating disorders. In terms of lifetime, it's about 8% in females and 2% in males, which tells you there is quite a big difference in ratio between how females are affected in comparing to males. The most common eating disorder is still the eating disorder not otherwise specified, which means it has bits and pieces or certain traits of certain disorders, but doesn't fit the full criteria. So it can have some symptoms of bulimia, some symptoms of anorexia, but not meeting the full criteria, and therefore this seems to be the most common. Followed by binge eating disorder. As you can see, this is, of course, something we suffer from in Kuwait and leading to obesity. Bulimia nervosa, and finally anorexia. So anorexia doesn't come at the top of the list at all. It is one of the rarest. But at the same time, it is one of those disorders we have to focus so much on because out of all mental health disorders, it has the highest mortality rate. People with anorexia nervosa can reach up to 18% in terms of mortality rate, and this mortality is a combination of both suicidal, ideation and acts, and of course the medical complications from anorexia and starvation. The point prevalence of eating disorders, it actually is doubling and increasing over an 18-year study when they looked at it between 2000 and 2018, which also tells us that it's rising in parallel to obesity. So not only obesity is rising, also other eating disorders as well. What about epidemiology for anorexia specifically? As we said, it is definitely more common in females than in males. The prevalence is usually 12 times higher in females comparing to males, and even in clinical settings, it still tends to be for every 10 female patients, there is 1 male patient. And the median age for anorexia nervosa specifically is actually in the adolescence. And therefore, it's very important for us to pick up on this early, since these patients are in the prime of their life, and if it is not caught early, we know prognosis-wise, the longer they've had the disease, the more difficult it is for us to treat them. So what are the etiology? Of course, you know, in psychiatry, when we need to analyze a patient or when we need to analyze a case, we always start with predisposing, precipitating, and maintaining factors, okay? So what are the predisposing factors that can put a patient at a higher risk to develop anorexia nervosa comparing to the general population? Genetics seem to play the highest role, and like many other mental disorders, so it's basically the small effects of many distinct genes that can lead to this, and not just to the anorexia specifically, also to the comorbid disorders that come with it. So if a patient has a family history of anorexia nervosa, someone else in their family, or any eating disorder, they are at a higher risk than someone who has no family history at all. Therefore, when we are assessing patients, it's important that we ask about family history of psychiatric disease in general, and specifically about eating disorders. Number two, of course, the sociocultural pressures for thinness, and we know this and we cannot deny it, especially for females. The amount of pressure that females go through in order to look a certain way or to be of a certain image is huge. And that's one of the risk factors that put our young teenage girls at risk to reach that model look or to look like this specific celebrity, okay, and take, unfortunately, extreme measures to reach there. The elevated shape and weight concerns, dietary restraints, exercise, and of course, if there is also that culture or family history of eating and weight control behaviors within the family. So not only the genetic, but also the role modeling plays a big role in how it affects our patients, right? So now we know this, for example, in Kuwait or even in the Gulf region, the whole obsession with needing to look a certain way, whether it is through healthier means like exercising or unhealthier means like using diet pills or diet injections now. And I'm seeing this in my practice, the severe weight drop that I see people are going through in order just to meet that expectation or to kind of catch up with the pressure of society in how a female is supposed to look in order to look beautiful. What are the precipitating factors? So if somebody already, we talked about predisposing, so putting them at risk, what could be factors that put you to, or trigger the disease to start? For example, if you have an already premorbid low BMI, that puts you at risk. If there is a continuous or a chronic dieting behavior, that also puts you at risk. If there is an inherent leanness or constitutional thinness precipitating, for example, if the person is already petite and thin, okay, that can put them at higher risk or precipitates the disease more than someone who is of a higher weight. And of course, we have certain behaviors like excessive exercise can sometimes precede the onset of dieting behavior. So there are certain behaviors we need to look out for and characteristics in the patient that sometimes can precede the actual onset of the disease. And what about the maintaining factors? So if a patient continues to restrict, this definitely appears to be a maintaining factors because of the reward they get every time they lose weight, and therefore it turns into a compulsive behavior. When I talk about comorbidities and differential diagnosis, I'll talk and compare OCD, okay, obsessive compulsive disorder, to anorexia nervosa, because there is a lot in common. And I'll also compare delusional disorder to anorexia nervosa. Believe it or not, even these three are very separate disorders, but there is common grounds. We also know that alterations in hormones and neuropeptides, like ghrelin and leptin, these are also associated with maintaining the disease, okay? And finally, once patients have a chronic illness or have a chronic, duration of their illness, the gastrointestinal complication of starvation and binge eating or purge behavior, okay, can also maintain the disease due to early satiety, gastroparesis, and the gastrointestinal reflux, and finally the constipation that can, lead to maintaining the disease because there are actual physical symptoms that the patient now develops. It's hard for them to break that cycle. What about the neurobiology? Is there a neurobiology to eating disorders? Of course. It's one of the most biological diseases out of all mental disorders. So there has been studies to indicate and prove that there are deficits both in the dopaminergic function, and which is always associated with motivation and reward. So dopamine is released at a lower rate in patients with anorexia nervosa, meaning that usually dopamine is released at a normal or higher rate for any normal individual when they have a meal, because it's considered a reward system that gets activated. Patients with anorexia, they've studied that dopamine release in those specific patients was not released in the normal amount. And therefore, these patients don't feel the reward we all feel, don't feel that pleasure level, and therefore they tend to either skip the next meal or even restrict. There's also evidence to show that serotonin and serotonin function is involved, which is usually the one to control mood, impulse control, and obsessional behavior. So patients with anorexia nervosa have a lower serotonin level in comparing to normal individuals. This is a beautiful, I once read this in a biography of patients suffering from anorexia nervosa, and I love the way it describes this disease. So it basically is a relentless pursuit to thinness. Relentless meaning never ending, and the patient never gets tired. Pursuit, that's their aim, okay, and their goal is thinness, which is unfortunately like a vicious cycle that never stops. So this is a second clip from the podcast that I would like to just...
اللي عندهم أنوركسيا مهما ضعفوا يشوفون نفسهم تان.
Absolutely.
هذا
عندي
صدق.
هذا absolutely. It's very vicious.
يعني أنت على وزن 35 ممكن تشوفين نفسك متينة؟
إيه.
اوكي
إيه.
يعني هذا بالعقل it doesn't make sense صح؟ بس أنت تشوفينها كذي.
إيه.
وهل لو ما في خلينا نقول أي تبعيات، خلينا نقول لو ما كنتي دايخة، لو ما أهلك ضغطوا عليك ولا شيء، تكملي؟
Absolutely.
توصلين لوين؟
ما أتوقع I don't see
تختفين بعد
إيه.
خلاص.
Okay, so basically in this specific clip, the patient at one point reached a weight of 35 kilos. 35 kilos. And my question to her was, if there were no complications, if there were no medical complications, and if there were no pressure from your family to get treatment, will you continue that pursuit to lose more weight? And as you can see, she said, absolutely. So this is not something that the brain or the logic will stop her from doing. She will continue to lose weight regardless of what is the number on the scale. And of course, that's why patients with anorexia nervosa, we always discourage them from weighing themselves because there is this obsession about number that they have. And of course, it all goes down to control. But this is a very important point to realize why this is a very dangerous disease if not picked up or treated, because this patient will continue to starve, will continue to do whatever it takes to continue losing weight. Okay, so when we talk about diagnosis, we need to go to the DSM-5, okay, which is basically the main book to give us the different criteria of mental disorders, so we don't overdiagnose or underdiagnose. So according to the latest criteria and DSM criteria, you need each of the following 3 symptoms. You have to have restriction. So they're restricting energy intake that leads to low body weight given the patient's age, sex, and development. You have to have intense fear of gaining weight. And that's actually a core feature of anorexia. They have a phobia from getting fat or getting, of course, fat in the definition of patients with anorexia is very different from all of us. But they have that intense fear of gaining weight. And finally, they have a very significant and distorted perception of their weight and body shape. Okay, so there was a very interesting exercise that they used to do for patients who are hospitalized in an inpatient setting. And I remember that was done when I was in Canada. So we would have the patient stand next to the wall, okay, and someone will just come and draw around the body shape on the wall their body size, okay, with a pen or with a pencil. The patient will step back, and then we will tell the patient, okay, do you see this is your, basically, circumference, this is your body shape, and it was just literally, it was painted or basically drawn while you're standing next to the wall. The patient does not believe that this is how they look. And when they were given the chance to draw their own body shape, it was at least 3 to 4 times bigger. So you can see the significance of perception distortion that they have. It reaches a point of a delusion. And that's why when we talked about comorbidity, I'll discuss this more. In terms of severity, we have different severities, of course, of anorexia, and that's according to DSM-5, is calculated based on the patient's BMI. Okay, so it's mild if it was between 17 to 18.49. Of course, the most severe one is less than 15. And at this point, patients usually require hospitalization in order to stabilize them vitally and medically. So what are differential diagnoses we always have to keep in mind? Of course, eating disorders, other eating disorders would be something to rule out. What's the difference between bulimia for those asking, for those sitting? Of course, there are many common factors between, because even bulimic, they have fear of gaining weight. Even bulimics, they have a distorted body image. Even bulimics, they have unhealthy, lifestyle with food, and they have an unhealthy relationship with food. And by the way, even anorexic patients can binge and purge. Even anorexic patients can have the purging and vomiting behavior. So it doesn't mean the purging, it's always associated with bulimia. That's not correct. You can have both behaviors and both disorders. Really, the differentiating point is the BMI. So if the patient is above 18.5 BMI, they cannot be anorexic. Okay, I remember a doctor I trained with in Canada. He was an eating disorder specialist and did one of the most largest studies on the use of antipsychotics for anorexia. I didn't agree with the way he described patients with bulimia, but I think there is some truth. He said a bulimic patient is a failed anorexic. Unfortunately, it's very harmful, it's very harsh to say that, but I said, what do you mean? He said, they want to be anorexic, but they can't, because they cannot reduce their weight, but they have similar behaviors, So remember, the BMI is the differentiating point. What about this avoidant or restrictive food intake disorder? Maybe this is not very common to many patients, but I want to clarify it because you might run into it in your practice. So those patients do restrict their energy intake, and they do restrict food. However, it's not due to fear of gaining weight. It's not due to fat phobia. It is coming from one place: aversion to the sensory characteristics of food, the smell, the appearance. And they also have concerns about the aversive consequences of eating. I don't know if you've seen any of these patients. I see them, especially even in teenagers and sometimes in children. The fear of choking makes them not eat. The fear of unable to choke or not being able to swallow makes them avoid food. And sometimes patients tell us they really have this aversion reaction to food, the smell, the taste. It is not about wanting to lose weight at all. So once you dig a bit deeper into the history, you realize it's not about that. It's more about they have an unhealthy and kind of a hate relationship with food. That's not anorexia. Okay? Of course, differential diagnosis, because it's a differential and it's a comorbidity. Depression, very common, of course, with anorexia. But when you have a patient who's lost weight, it could be due to depression. What's the difference? Patients with depression, it's not about weight gain. And it's not about fear of losing weight. It's due to the depression that they've lost weight. And the main difference, too, between anorexia and depression, what is the energy level usually with patients with depression? Is it low or high? Low, right? So patients with depression usually are bedridden, they don't want to get up, they rarely have the motivation to do anything. What is the energy level with patients with anorexia? Actually, it's very high. Otherwise, how are they in the gym every day, 3 to 4 hours? How are they excessively exercising? So ask about energy, because energy tends to be one of those differentiating factors. Social phobia, because a lot of anorexic patients are very introverts and they don't speak in public and they hide. However, patients with social phobia realize, that their fear is excessive and unreasonable. And finally, OCD. Because patients with anorexia have an obsession, right? Repetitive, distorted thoughts about weight gain and about weight loss. And therefore, is it OCD or is it anorexia? Again, patients with OCD, they know that these obsessional thoughts are unreasonable and unlogical. Patients with anorexia, they don't. Actually, it's very hard to challenge patients with anorexia because they do believe that they're right. They do believe that that's the way it should be. So this is another differentiating point. But there is a lot of common ground and common factors between the two. Okay. Also, body dysmorphic disorder. Probably all of you were wondering what's the difference. Body dysmorphia is something that's usually in 70 to 80% of patients is associated with shape of the face, and the head, and therefore most plastic surgeons see patients like that, and of course dermatologists. It's not related to weight gain. It's not. You can have a patient with body dysmorphia, their average weight and maybe overweight, they still have body dysmorphia. So it's not related. You always want to know, is it weight related? It is really weight related with anorexia. And finally, psychotic disorders. Why did I mention that? Because it's still hard for us as psychiatrists to differentiate. Is anorexia nervosa a delusional disorder Or is it only an eating disorder? Because of how fixed and false the belief they have about their own body image and their own weight and their own health, that sometimes we wonder, are they delusional? That's why out of all medications, when I come to talk about treatment, antipsychotics seems to be the most significant in terms of response. What are the comorbidities for anorexia nervosa? It's always important to know that it's very rare for you to see someone pure with anorexia nervosa without any comorbidities. Anxiety disorders, obsessive compulsive, as we said, body dysmorphic, PTSD, depression, substance use, of course, and even impulse control. I want to mention that there is a personality trait usually that also occurs with patients with anorexia nervosa. It's more of the OCPD, obsessive compulsive personality disorder, because patients with anorexia nervosa, their main issue is control. Their main issue is control. So food is just the representation or the reflection of that control. They believe that they can control themselves by controlling their weight, control themselves by controlling their body shape. And they relate that to their self-wellness and also to relate it to their achievement. So the more I lose, the more I've achieved. So it's the personality is very different from patients who have bulimia. Bulimia, it's mostly borderline personality. Okay, borderline personality is associated with impulsivity and lack of control. So we have to differentiate, Anorexia, a lot of control. Bulimia, actually lack of control. And that's why what happens with bulimia, they binge and then they purge. When you binge, you lose control. When you purge, you lose control. Okay, whereas anorexia, most anorexic, they actually use restrictive behavior. So that's a lot of control in the way they eat. Okay, so of course, in terms of evaluation for you guys, when you see a patient with anorexia nervosa, we have to start with the medical history. These are the main symptoms patients with anorexia can present with. They lose their periods, of course, due to their low body weight. And the fatigue, the weakness, the palpitations, dizziness, that's all very common. In terms of physical examination, it's very important to look at the weight, of course, and the height, and calculate the BMI accordingly. Vital signs are vital to be taken, since we mentioned that patients sometimes are so medically compromised that they need to be hospitalized just to stabilize them. Cardiovascular and skin examination is important. And then, of course, I'm not going to run into each physical sign, but basically, the physical signs are representations of the starvation and the low body weight that these patients present with. But there is a very interesting, and probably from medical school you would remember, if you look at the picture of patients with anorexia nervosa, that brittle hair, that very dry skin, okay, that never escapes you, and the sunken eyes and the very prominent cheekbones are usually very prominent for any patient who comes to you with anorexia nervosa. Now, keep in mind, patients with anorexia are also very, very smart, and they're high achieving. So when they come to the doctor's office, they're rarely wearing tight clothes or open or exposure clothing. They actually cover their body. They wear layers. They're the patients in the hoodies and the tracksuits. They don't show off their body because they're very ashamed of their body. So it's not easy for you to pick up that they're that thin. I've asked a few patients in my office, even though it's not my role to do a physical examination, but I do tell patients, would you mind taking that jacket off? Would you mind taking that top off? I need to see, what are we talking about? Okay, and you'd be surprised of what you see underneath these layers. So they really do a very good job in hiding them. So these are the main lab work that you need to do. Of course, the CBC, the electrolytes, glucose level. For girls, pregnancy test is important. For men, testosterone, and ECG and liver function test. So these are just the basics, and depending on whatever comes back abnormal, you need to follow it up. I know I only have 4 minutes, so I want to rush into the treatment. Basically, the treatment of anorexia nervosa can be divided into 3 settings. Inpatient setting for patients who are medically unstable, nutritional rehabilitation or partial hospitalization, day hospital as we call it, which is more of an intensive outpatient program. And finally, for those who are stable, they can just follow up in outpatient program. What is the criteria for admitting patients? It's really related to their medical instability. So if you have a pulse less than 40, blood pressure very low, orthostatic increase in pulse, cardiac arrhythmias, basically marked dehydration. These are patients that we don't need to even argue about. They need to be hospitalized and they need to be stable first, sometimes even by refeeding syndrome, okay, or refeeding them by force if they are minors, and then after that to be transferred to the mental health team. Now, in terms of psychotherapy, it's actually the main treatment for anorexia, more than pharmacotherapy. So as a psychiatrist, yes, I use medication with my patients, but it is not the mainstay treatment because these patients, their main problem is their core beliefs, right? So what is the main type of therapy that works for them? CBT, psychodynamic, even motivational interviewing involving the family is very important, okay? And those who don't respond to psychotherapy, then we can move on to medication. In terms of medication, as we mentioned, it is not the initial or the primary treatment, okay? Usually, and studies have shown that if you use a low dose of olanzapine, which is an atypical antipsychotic at a low dose between 2.5 to 5 milligrams, it has shown significant improvement for patients specifically due with the weight gain side effect of olanzapine, okay? Yes, just some prescribing considerations to keep in mind. Because we are talking about very underweight patients, very dehydrated patients, medically compromised, please always start with much lower dosage than your average, okay? These patients can have a higher serum level due to their increases in the percentage of unbound drug in their serum and the decreased body fat, or you can have actually poor drug absorption, okay, due to other gastrointestinal complications that they have. So these patients, you're not working with a very normal baseline, okay? Keeping in mind that you need to be very slow and very small in your dosages. There is an antidepressant called bupropion. I wanted to mention it here because it's one of the antidepressants we do use commonly for depression, okay? This is definitely contraindicated in anorexia because of the fact that it increases seizure threshold and it is an appetite suppressant. So you really don't want to be using it with your anorexia patients, even if they do present with depression. I would go for SSRIs, SNRIs, but not bupropion. So this is the study I was talking about. It's an RCT that was done in 2008. And basically, it looked at olanzapine and the use of it as an initial treatment to at least help patients stabilize their mood and to restore some of their body weight. And it's been very successful. That would be the first and the only antipsychotic that has shown positive results with that. So no compelling data that says adjunctive antidepressants actually restore body weight. But of course, we use them only if there is a comorbidity that needs to be treated. Depression, OCD, anxiety, but not for anorexia per se. In terms of relapse, unfortunately, patients with anorexia do relapse, and it is a chronic disease, and it is remitting and relapsing. So it is not one of those diseases that can recover completely. However, if you look at just the numbers, approximately 50% do have good outcomes, 25 intermediate, and 25 have poor outcome. As I mentioned earlier, 18% mortality rate with anorexia is quite high. So what are the factors just to differentiate between better and poor outcome? If the patient is insightful, if they have good relationships, if the patient is willing to accept the treatment and of course is medically stable, and lack of comorbidities. On the other hand, if the patient presents with anorexia at a later age, it's hard. If they have a chronic or a long duration of their illness, it's hard. If the patient has comorbidities, and of course, even if they're medically compromised with a very, very low BMI, it's actually a poor outcome. I just want to end with my final clip, just to give you some, as we say, the highlight of the talk.
على الرغم من أن أهلي are very understanding, very open-minded, بس متى اقتنعوا أن الصج I needed help أو الصج أن الhelp was a good action to take لما صرت الحين stable وزني زاد and I'm comfortable with قالوا oh yeah you're right you were right إن أنت كنت تحتاجين help. يعني أنا لما جيت to come and see you ما كانت advice من أهلي، يعني أهلي كانوا
كان قرارك؟
كان قراري 100% وقرار close friends بس ما كان قرار أهلي. يعني أهلي كانوا يقولون روح حق نيوتريشنست بس
ما يشوفونها من ناحية نفسية أو منتل
أبداً. فلما عقب شافوا positive results اقتنعوا. فاللي أنا بوصل إنه يعني أنا جاية من environment very very healthy very open minded
وايد ومو بس كذي ما شاء الله وايد educated.
absolutely.
بيتكم ما شاء الله يعني الوالدة والوالد وخواتك وإخوانك كلهم ناس دارسة وفاهمة، فتتوقعين إن هذا الشيء مفروض سهل إنه ينفهم بس مو سهل.
لا يعني أنا أقول الله يعين الناس اللي environment أصعب من my environment.
شنو نصيحتك أو شنو الرسالة اللي ودك يعني توصلينها نورة قبل ما نختم؟
أول شيء إذا الشخص نفسه لما يكون undergoing the start of anorexia ما راح يشوف ما راح ينتبه حق الساينز، بس الأشخاص اللي حوالينا should تتدخل. إذا صار وما تدخلت الشخص لازم ما يستهين بهذا الشيء، لأن ما حد يستاهل إنه يعيش مع حرب مع شيء نعمة من الله يعني
متعة.
أي يعني it's not comfortable at all. يعني torture كل يوم is torture. يا ريت الأهل ينتبهون خصوصا على التينيجرز أو الشخص نفسه لا يستهين
أو لا يهمل.
absolutely.
يعطيك ألف عافية. Okay. Thank you so much. يعطيكم العافية. Thank you. I apologize for going a bit over time. Sorry.
Thank you so much, Dr. Mariam, for the interesting and very informative lecture. We have few questions here. First question, since anorexic patients already have a dopaminergic deficit, can't olanzapine treatment induce schizophrenia-like negative symptoms?
Okay, so basically olanzapine, as you know, is used also to treat patients with schizophrenia. So the pathology or the neurobiology is quite the opposite. So patients with anorexia have low dopamine. Patients with schizophrenia have high dopamine. So by you treating with olanzapine, you're replacing, you're not replacing, the dopamine to be increased. You're actually more working on the side effects of olanzapine as a mood stabilizer and to increase serotonin, not dopamine theory. So the two pathologies are completely the opposite. Yeah.
The second question is, how do we convince patients with anorexia that they have a problem in order to accept referral to psychiatry?
Yeah, that's a very hard question. And as you can see, the patient herself, she said, and sometimes even family members, they don't accept or they don't pick up on the fact. And even if they do pick up on the fact that their child has a problem or their daughter has a problem, unfortunately, the referral is not necessarily to the right specialist. They would just focus on the physical signs by transferring or referring them to nutritionist. Patients with anorexia are usually very difficult to convince. They're very, very stubborn. Okay, so usually it's the support of others, family and friends who can point out and tell them about what they're realizing or what are the losses that they're going through due to their illness. But I want to be very realistic. It's not very common that I see patients with anorexia coming to me as soon as the disease starts. Usually they come to me after years and years of suffering, and sometimes it's pressure by those around them. Or if they are suffering from a comorbidity, that they would like to treat the comorbidity. Do you know what I mean? So they're depressed, they want to see me for the depression. They have anxiety, they want to see me for their panic attacks. They don't want to go there into their anorexic zone. But once they come, of course, now we try to address this. But in general, it is it's a challenging point, yes.
There is another question. How urgent do we refer patients with anorexia nervosa to psych hospital if they have no medical instability?
So if they're medically stable or not stable?
If they have no medical instability.
Okay, so if they are medically stable, of course, if the patient is agreeing, and the main indication for hospitalization to a psychiatric unit is suicidality and self-harm. If the patient is not within that category and they are medically stable, they can totally be followed up in an outpatient setting.
Thank you so much, Dr. Mariam.
Thank you so much.
Please accept our trophy of appreciation.
Thank you.
So we'd like to thank our moderators, دكتورة ندى العميري. دكتورة طيبة الحسن. دكتور مهدي الهاشمي. And now we have an announcement for our poster competition winners with the head of the poster evaluation committee, دكتورة تهاني الأنصاري. Welcome دكتورة تهاني.
وفي مؤتمر الرعاية الصحية الأولية الخامس وامتداداً للسلسلة الأكاديمية والعلمية التي أضاءت مشاركات في مسابقة الورقة الأكاديمية بوستر كومبيتيشن تحمل شغفاً علمياً واهتماماً للسعي لرعاية المريض. يسعدنا أن نعلن عن الفائزين الأوائل الثلاثة. In the 5th Kuwait Primary Healthcare Conference, and with extending the academic and the scientific advancement through poster contribution and competition that reflecting passion in scholarly role and patient care. The first prize in the Quality Improvement Project will be Dr. Muna Al-Mtairi. المركز الأول في التدقيق الكلينيكي كلينيكال أوديت دكتورة أمينة العلوي. المركز الأول في مجال البحوث ريسيرش دكتورة كوثر الجساسي من سلطنة عمان الشقيقة. نشكر مشاركة الجميع. تفضل دكتور. نشكر مشاركة الجميع في مسابقة البوستر. نتمنى لكم مزيد من المشاركات في المؤتمرات القادمة. شكراً.
So, Dr. Dina, can you please come on stage to award our judges? So we'd like to now award our judging committee for the poster competition, starting with the head of the poster competition committee, Dr. Tahani Al-Ansari. Dr. Adnan Lugayan, who couldn't be with us today. دكتورة ملكة سرور. ياسين يحيى. دكتورة تسنيم الجاركي. دكتور بسام البطحي. دكتورة نسيبة الكندري. And finally, Dr. Sheikh Al-Kindiri, who couldn't be with us today. So now we'll have a short break. We'll have a group photo with all the committee and the winners. So can we call the winners of the poster committee to have a group photo with the committee? Thank you very much. Now we'll have a short break till 10:15 and we'll be back at 10:15. Thank you.